Welcome to the Successful Impression Techniques webinar with Dennis Urban, CDT, Director of Clinical Education. Dennis Urban has over 40 years of experience in the dental technology field, including lab management, manufacturing, technical training, sales and marketing, product development, quality assurance, writing, and lecturing. Dennis has been an eminent lecturer to dentists and technicians worldwide since 1985. He's also a formal dental laboratory owner. His lectures and trainings span many areas of dental technology, including digital technology, removables, implant dentures, shade communication, and occlusion. His technical articles have been published in numerous dental publications in the US, Canada, Europe, and Asia. Dennis now serves as the chair of the National Board of Certification in Dental Technology and is on the advisory board for IDT Magazine. And with that, it is my pleasure to say, take it away, Dennis.
Wow, thank you, Jessica. Thank you so much. And thank you, everybody, for joining us tonight. We have a nice, informative lecture here on successful impression techniques. And I know a lot of us are coming off a long weekend, and I'm glad you're here tonight with us. So we're going to start off with some facts here as far as digital and traditional impressions here. And if you look here on the screen, you'll see, this survey only goes to about 2019. And this is a survey that was done by the National Association of Dental Laboratories here in the United States. And you can see on the digital side, from 2017 to 2019 versus traditional impressions, so we're getting more of an increase in digital impressions in a laboratory, but there's still the majority of impressions are with traditional impressions, and that's what we're going to cover tonight, because I've been asked so many times about, traditional techniques and impressions and successful techniques. And one of the things that I remember when I had my laboratory, I was in a building with about 8 to 10 dentists, and I was constantly being called chairside, even when they were taking impressions with it. And I've seen impressions taken from anyone from the assistant to the dentist, and and I got to see what to do and what not to do. And after I sold my laboratory, I wanted to work with one of the largest impression material companies in the world, and we did a lot of seminars and educational programs on impression taking. So we're going to utilize some of that information tonight. And at the end of the presentation, I'm going to touch a little bit on some digital protocol also. So let's get started. I'm just going to adjust my screen here real quickly. Here we go. This way I can see what I'm talking about here. So what are we going to talk about tonight? We have a lot that we're going to pack into 1 hour here. We're going to talk about the history of dental impressions. I did a little research on the history of dental impressions. It's pretty interesting. I'll show you that in a minute. And we'll talk about predictability with impression techniques and materials, avoiding air entrapment, avoiding tearing and distortion, adequate inspection of the impression after removal, moisture control, cleanliness of the tooth preparation, tissue retraction. We'll talk about cord retraction and paste retraction, single unit crown impressions, multiple unit crown and bridge impressions. We'll talk about preliminary impressions on full dentures, custom tray impressions, pickup impressions with the repairs and crowns underneath the partial. And then we'll talk about also with overdenture reline impressions. And so a lot of things we're going to be covering tonight. You're probably saying, wow, that's a lot of material to cover in an hour. But those of you who know me well and have been to my webinars and seminars, I pack a lot into 1 hour. So I move pretty quickly, but we'll have some questions and answers at the end. So let's start off with the timeline of the history of impression materials. And this is pretty cool to see where we started in the 18th century all the way to the 21st century. So starting with the timeline with impression materials, if you look here, in 1787, John Greenwood started utilizing beeswax for impressions. And for those of you who still use beeswax for bite registrations, I used to get quite a bit of this type of material in the laboratory with the bite registrations. And I remember when I first started my laboratory, I actually got full up and full over impressions taken with beeswax. And that was a long time ago. That was in 1980, I think it was, I received that impression. And then we go all the way to 1820, when C.F. Del Bar, he invented the first and utilized the first metal impression tray. And from there was 1844, and then John Greenwood's grandson utilized plaster of Paris for impressions. and I remember when I first started in dental laboratory back in 1975. Now I'm aging myself here, but back in 1975, we used to get a lot of plaster impressions of a crown and bridge, and they used to be in a metal tray, and the impression used to be broken apart, and we used to have to put the parts together because once that plaster of Paris set in the mouth, of course, we had to break it apart, so it was locked into the tooth structure. So we had to put it together, put a separator in there, pour a model, and then separate it again. It was a lot of work that we had to deal with impressions of plaster in Paris. So from there, in 1848, Montgomery utilized gutta percha as an impression material. And we all know what the gutta percha is used for with the root canals. And that was used in 1848, actually. And then 1862, Franklin utilized wax with a plaster wash. Now, I'm just curious if there was ever a picture, I would like to see what that looks like, because it seems kind of difficult with wax with a plaster wash internally, with an impression. So, but we're getting towards, we're getting there, and we're progressing here. So I'll show you the next slide and how we jump from 1862 to 1874, when S.S. White came out with modeling plastics. And but when those modeling plastics came out, they really weren't utilized in the correct way. So in 1900, the Green brothers introduced the method for taking impressions with modeling plastics. And the first post-dam was utilized for full impressions at the time. So they realized that a good post-dam and an upper denture created suction, and they were utilizing that post-dam area and getting those anatomical landmarks captured in an impression. So pretty good stuff. In 1915, Rupert Hall had the first custom tray made. He used a black modeling plastic, probably the same type of modeling plastic that was used for impressions. And then we jump to 1925, when polymer agar, which is a hydrocolloid material, was used for dental impressions, but not for fully edentulous patients. So let's go to 1920, when impression waxes were developed, and that was utilized for taking impressions also, in 1920. And then we jump to 1930, when Ward and Kelly first used the ZOE, zinc oxide eugenol, for final impressions. And let me tell you, when I first started my laboratory, we used to get a ton of zinc oxide eugenol impressions, or ZOE impressions, on denture cases. They had the only thing that used to drive us crazy is because when you poured a model with zinc oxide eugenol, it used to stick to the model, so you just had to break it apart, and it really was difficult to get out of a tray or out of a denture that was utilizing this impression for a reline. In 1940, Wright & Denon has the first alginate impression that was used for a corrective wash procedure, like a wash impression. That's when alginate was first used. And then we go to the final three here is back in 1955, less American impressions were introduced, and polysulfide and a silicone base were utilized for impression taking. And in 1973, the first moldable acrylic material was introduced, and tissue conditioning and functional impressions were utilized by using this material. And that same material is still out there today with tissue conditioning and functional impression taking. And finally, back in 1982, 3M SP came out with vinyl polysiloxane, or VPS impression material. And they've advanced and improved the material over the years. All different companies jump on the bandwagon, and they really got these impression materials to the point where they're so exact, and if you're utilizing the right material and the right company, and for a successful impression. So that's a pretty cool timeline from when it first started to where we are now. That's 1982, but even from 1982 till now, those 3M material, that vinyl polysiloxane, has just been improved by a number of companies. So we're going to talk about that in a minute. So what do we need for a successful case? The essentials, of course, the correct materials, a good shade, accurate shade, good bite registration. But most importantly is a good, accurate impression. And I think the number one phone call we make in the laboratory is on impressions. And if you look at the remake factors in a laboratory, number one remake factor is inadequate impressions. So we're constantly calling the doctor on inadequate impressions. And number two is inaccurate occlusal registrations. And then poor trade communication is 3, and the wrong choice of materials. And we talk about the wrong choice of materials. It could be anything from an implant case to an overdenture case to utilizing the wrong materials for these types of cases. So number 1, though, is inadequate impressions. So let's talk about VPS, or vinyl polystyrene. What are VPS impressions? VPS impressions are made with vinyl polystyrene impression material and are widely used industry-wide by dental professionals. And the material is intrinsically hydrophobic. So to increase the hydrophilicity of the product, soap-like molecules called surfactants are added. So even when we get a VPS impression in a laboratory, we have to use a surfactant so it becomes hydrophilic, and it attracts that moisture. And VPS materials are also sometimes called PVS materials and or polyvinyl siloxane. So what are the different kinds and different types? Well, they're available in multiple viscosities for precision impressions. So we want to make sure we utilize the correct viscosities for the correct restoration. And we're going to talk about that. And we're going to talk about some of the challenges that many clinicians have when taking impressions. And VPS impression materials are also available as an alginate alternative for the preliminary impression. But just be careful. I've seen a lot of these alginate alternative impression materials come into the laboratory where there's a lot of pulls and voids and they're just not accurate. So make sure you utilize a good quality material. This is looking at the auto mix type of material. This is a super hydrophilic material, or VPS material. As you can see here in all these auto mix cartridges, they're all different viscosities, different setting times, and things like that. A long setting time, medium or fast setting time. You want to make sure you have enough time to work with this material, with different types of impressions. And we'll get into some implant impressions in a little while, taking implant impressions and then taking impressions for crown and bridge and removables, dentures. So what about polyether? Well, that's another alternative to PVS and enables an excellent dental reproduction in a wet environment. And it also displaces moisture right from the start for a void-free impression. So you see a lot of the infragum or that type of impressions being utilized on the market today. So polyether is also a very, very popular material. So, and one of the benefits is polyether material offers high rigidity after setting to keep copings in place, also ensuring the precise placement of implants. So many times with an open tray impression, even a closed tray impression on implants, if there's no divergence issues, this polyether works fantastic with that. And it stays flowable throughout its working time, capturing the finer details with few voids. So let's start off with what causes this distortion. And like I mentioned before, the number 1 phone call we make in the laboratory before we start a case, we want to just do quality control on the impression, even before it's poured and after it's poured. And if we see distortions there, we're not going to go through with the case because it's only going to be a remake. So let's talk about predictability with impression techniques and materials and what causes this distortion. Well, if the working time is exceeded, the flowability is already impaired. So you want to select a material with sufficient working time that is regular set instead of fast set. So you just want to adjust your working time. You might have to have a few different viscosities and setting times in your operatory just to know how much time you have and what you have to work with here. And don't exceed the working times given on the instructions for use. Pay attention to the storage temperature because working times are reduced due to higher temperatures of the product. Usually the warmer the temperature, the faster the product is going to set. It's the same type of thing in a laboratory, dental laboratory. We're working there. If we're working with acrylics and different materials, even plaster and stone, the warmer the environment the faster these materials set up. So it diminishes the working time. Then we have delamination of the impression material and tray. This can cause to inaccuracies also. So you want to use a tray adhesive for all types of impression trays and then apply adhesive on the bottom and inner sides of the tray. And also use the tray adhesive on the gauze of the dental arch when you're using dual arch trays, rather. So, and certain trays have a self-retentive fleece strip, which eliminates the need for tray adhesive and fewer handling steps. And also what contributes to inaccuracies is a lack of support or insufficient stabilization of the tray during polymerization. So you need to support the tray until the impression material is sufficiently set. Stabilize the tray after seating and avoid any movements. I see a lot in the dental office. Who's ever taken the impression, sometimes I'll leave it in the patient's hands to hold the impression tray in place, and the patient's moving around, and you're going to get voids and an inaccurate impression. So you want to make sure it's stabilized. And when taking an impression on the upper jaw, you can easily find support on the chin or cheekbone of the patient. And with the impressions on the lower jaw, patients should close their mouth as much as possible without biting down onto the tray to avoid deformation. And try to avoid correcting the position of the tray after insertion. This is what I mentioned earlier. Once you start moving around a tray, you're going to run into problems, and you're going to have some inaccuracies or deformation. And there have been distortions during impression removal. You want to ensure the impression tray is the proper size prior to taking the impression of the material, and the material has excellent elastomeric properties. So, and then you're going to remove that impression along the axis of the prepared tooth. Don't try to go tearing in different directions, because it's going to be you're going to be distorting that impression. And make sure that the impression material is completely set before removing the impression tray. And select an impression tray is too flexible. Sometimes the trays you're using are too flexible. So you want to use a rigid tray. And when you're using a dual arch tray, impression materials with low flexibility and high shore hardness are beneficial to stabilize the impression. And utilize materials that offer heavy body options and that it's suitable to be used with dual arch trays. And some of the impression materials like Imprigum and those types of materials are great with these types of trays. So the combination of the tray and the impression material is not appropriate. This could also lead to distortion. Do not use a highly viscous putty material in combination with flexible plastic trays, because you can twist these and it's going to give you resistance, and you're going to have distortions. So dual arch trays can be deformed during impression taking by using highly viscous materials with flexible plastic trays. So what causes unclear margins in dental impressions? Again, we see this every day in the laboratory, and it's why it's so important to really inspect these impressions before they're sent out to the laboratory. So let's look at what causes these unclear margins in dental impressions. So main reason is thick blood and saliva pooled around the preparation, and it's not cleaned. And so you must rinse and dry the prepared area to stop any bleeding by using the appropriate retracting technique and a hemostatic agent. Liquids or pastes based on aluminum chloride, aluminum sulfate, or iron sulfate are suitable hemostatic agents. And when we talk about hemostatic agents, could be a retractable cord or a liquid. Some clinicians actually utilize both, and it works very well. So when you're using an astringent retraction paste, it's easy access to tight interproximal areas, has long-lasting hemostasis, and it's 15%, usually 50% aluminum chloride paste. So, and it's gentle on the tissue with less risk of tissue trauma and hemorrhaging, and it's better for patient comfort. And it has effective retraction. What has better retraction? I still think the cord has better retraction, but I think the combination of both of these, the astringent and the cord, you hit a home run. You really have the good retraction, and you can utilize it, get a good impression, and especially when you're taking a digital impression. Talk about that later, though. So the use of the retraction cord, the cord must be cut to the size for each procedure. And sometimes it's difficult to accurately place, and hemostasis is achieved by pressure, and usually requires the cord soaked in a hemostatic agent. So, and there's a risk of gingival inflammation and trauma, and a higher risk of hemorrhage. And it's sometimes painful for patients, but it has excellent retraction. So sometimes you have to put up with the negatives to get the positive on this type of procedure. So another, as far as unclear margins and inhibition of setting due to use of acid retraction materials and hemostatic agents, like I mentioned, you want to make sure you thoroughly rinse that preparation with water and dry it before taking the impression. And then also the inhibition of setting of the VPS materials due to contact with sulfur from latex gloves. I know a lot of the latex gloves are sulfur free now, but we used to get impressions in a laboratory, and it used to be in like a gummy state, or it wasn't even set up. We were wondering why this happened a lot. This is, when we first started getting impressions with latex gloves with sulfur in it. And that was the reason, because it had a reaction with the impression material. So you want to use gloves which don't contain any traces of sulfur. So nitrile gloves are the recommended choice. And impression material is stored at too low a temperature. That could cause inefficiencies around the margin and setting time. So temperature influences the viscosity, like I mentioned before. So store materials at room temperature, and so to avoid that temperature fluctuation and the setting time. And an incorrect storage of conditions of the final impressions. And after disinfection, rinse the impressions with water and dry before sending into the laboratory. So and want to store those impressions at room temperature and away from direct sunlight. So, and also inadequate disinfection. I've seen this many times. When we started, I started giving as far as communication courses and courses on disinfection. I saw that a lot of clinicians and even laboratories are using the wrong materials, the wrong glutaraldehydes, the wrong disinfection materials and sprays. So you want to use the recommended disinfectant and follow the manufacturer's instructions, and don't exceed the immersion time, because that could distort the impressions also. So what causes dental impressions to tear at the margins? So, well, smear layers from custom temporaries, that really plays a big part in it. And provisional cements, acrylics, or core buildup material that's present. So you want to be sure to remove the smear layer completely prior to the impression taking with alcohol or by polishing. And check the surrounding teeth also and tissue for any residue, and clean that residue off. So you want to, if you're making provisionals or temporaries, fabricate those provisionals after taking the final impression, or remove the air inhibited layer of the exposed preparation. So many of these light cure materials from temporaries, they have that oxygen inhibited layer. You want to get that, we're going to remove that. Otherwise it's going to have an effect on your final impression. And don't use impressions impressions already used to fabricate provisionals. So I know many provisionals they utilize an impression tray, and they inject the provisional material into the tray and then seed it in the patient's mouth. And sometimes that can distort it. And so you're going to, you don't want to use those impressions already used for fabricating the provisional. You're going to have some distortion there. And if the temporary is removed prior to impression taking, just remove all those residues around the tooth and the abutment tooth. So, make it nice and clean, because otherwise you're going to have a distorted impression. And then you have the premature removal of the impression. We want to make sure you follow the manufacturer's guidelines on setting time. Otherwise, you could have the tearing of the material, as you see here. And some of the impression materials has low tear resistance, so let the material completely set prior to removal of the material. So because that'll give you sufficient tear resistance. So what causes voids in the margins or dental impressions? Well, it's a lot of the voids are caused by mixing, when you're mixing or actually putting the impression material in the tray. So we'll show you a little short video in a second on this. So, and also blood and saliva contamination around the preparation can cause this. So you want to rinse and dry the prepared area like we talked about before. Clean that entire area. And improper syringe technique. You want to keep the tip permanently immersed in the paste to avoid any formation of air bubbles. And we see this a lot. It's taken out in the impression, put it back in there, and you're going to create air bubbles. You want to apply a liberal amount of wash material into the sulcus. Start from the bottom up and cover the whole abutment tooth with syringing material. And always keep the tip in close proximity to the surface. So, and when utilizing the auto mix cartridges, bleed those cartridges prior to loading the syringe, because sometimes you'll get more of one side of the material than the other. You might have more of the base come out or more of the catalyst come out, and that's going to give you an insufficient mix. So do not stop and start while loading the syringe. So as you can see on this video here, this is just an auto mix cartridge here, and it's put into a metal tray. But you see just constant contact with the impression material and no lifting away from the impression material, so that that doesn't create any voids. All right, there we go. Just an indication just to show you what to do here. And if you're using a multiple stage impression type of material, if you're using a putty first, or a monophase or heavy body material and coming out with a lighter body material, the same thing. You want to make sure you don't take that out of there and take that tip out of the impression material and create voids. All right, so moving along here, and let's talk about crown and bridge impressions. So Most of the crown impressions we get in the laboratories are with triple trays. And, with triple trays, you have to be careful, so when usually you're using a light body impression material to the prepared teeth or to the prep. And this material is less viscous and wets the surface of the preps better. And then a heavy body material is placed in the tray and then placed over the light body material to form the impression. And many times this works very well, but you make sure the tray is the correct tray. We talked about a tray before that's going to be too flexible. Make sure it's a pretty rigid tray. And the heavy body material provides stability, but the impression tray needs to be stable also. And then the patient bites into the impression material until set, about 4 to 5 minutes, unless you have a faster setting material. And, we get the impression of the opposing dentition and then the good impression of the prep and the abutment teeth that we're going to make these crowns on. So let's go to implant impressions now, and then implant level or abutment level impressions with open tray or closed tray techniques. So let's talk about when to use the open tray and when to not to use the open tray. So let's go through some of the specific techniques here. So on the open tray technique, you can utilize a stock tray and make your own openings where the implants are. I like to make a custom tray when it comes to this, and this way we know exactly where the implants are. We can make those custom tray with the openings, so it alleviates any extra time for you in the operatory. And what's great also, using CAD/CAM produced trays, we do a lot of these CAD/CAM trays with printed trays, and we know exactly where the implants are placed, and the openings are made in the tray when the tray is printed. So CAD/CAM produced trays are excellent for the implant impressions. So this is just showing an open tray impression. Doctor actually cut out openings in the stock tray here. It's just taking out a mouth here. A little trouble with the driver there. Impression tray is taken out of the mouth there. It looks like everything's in place. And then this showing the impression. Look at the divergency on those implants here. So we'll talk about that in a second here, about the divergency. So open tray technique. The impression tray is coated with adhesive and loaded with heavy body material. And concurrently, a light body impression material is expressed around the copings to capture the morphology and the soft tissue. Now, this is really important. A lot of times we'll get implant impressions in a laboratory and it's missing the impression of the soft tissue. And we need that soft tissue, especially when we're doing cases with single unit crowns. We need to know the cuff heights and even on implant dentures and overdenture cases, we need to know the cuff heights and we need a good impression of the soft tissue. So monophase impression material can be used as a convenient and practical alternative to the combination of heavy body and light body consistency, but I like a light body and a heavy body. So, and you could take a Q-tip and wipe it across the occlusal opening to expose the occlusal aspect of the copings so the screws can be located. So clean off the heads of those screws so you can put your driver in there easily and you'll know exactly where they are. So, it's just, gives you easy access for the loosening of the screws. So this open tray technique for a single unit screw retained crown, as you see here, we have the coping, impression coping in the mouth here. The doctor cut an opening in this tray, the stock tray. Felt comfortable using the stock tray on this particular impression here. And some lighter body material was put inside around the coping area. Then a heavy body material was there, put there. And you can see, it's hard to see on the bottom here, all the way on the bottom right, you can see there's a lighter body material around the single unit retained crown with a heavy body material. So this is an open tray impression for a single unit, single screw retained crown. So closed versus open tray technique. Let's talk about that for a second here. So, the open tray technique is specifically indicated when the implants are not sufficiently parallel, like that impression I just showed you a little earlier. and it's not parallel to allow an impression to be withdrawn from multiple impression copings. I know that was only 2 units there, but sometimes I'll see, even with multiple units, maybe 4 to 6 implants, and they're divergent. The best way to utilize an impression is an open tray technique. And the closed tray technique is utilized when the implants are sufficiently parallel to each other. Both can be used, on a closed tray technique. I've seen many closed tray techniques, but they have to be parallel. If you have something that's divergent, I recommend the open tray technique. So let's talk a little bit about the closed tray technique. Just some photos here from a few different doctors, and even Spear Education on the bottom here. It just shows you, single unit implant that's being done here, and the impression coping, the lab analog, model analog, and the both of them screwed together here. So a stock tray or a custom tray can be utilized in the fabrication of a closed tray impression for a fixed complete denture. A closed tray impression coping, they're placed on the implants or multi-unit abutments, and the impression is made. Very simple. And once the impression material polymerizes and is dislodged from the closed impression tray coupling, then we put our lab analog in there, and we can either do a soft tissue around that analog there and pour a model. So the combined coping analog assembly is then inserted into the definitive impression before we pour it. So it's real simple. We get quite a bit of the closed tray impression techniques, impressions in the laboratory on a daily basis. So let's look at some special considerations when it comes to implant cases now. So I wish we had more time. I know we only have an hour here, or 45 to 50 minutes. I'm going to have some questions, but I'd just like to mention the special considerations, especially when you're taking impressions on implant denture cases or hybrid type cases. So, this is a Noble Procera hybrid bar that we're going to have a denture made over at a hybrid type denture. But this special protocol that needs to be followed. And, as you can see here, I'm not going to go through all the protocol here right now. I have this protocol in one of my other presentations called Protocol, Procedure, and Patient Acceptance on implant dentures. So stay tuned for that in the future. That's a great presentation that covers all aspects of implant dentures. But the 4 I want to concentrate, or 5 I want to concentrate on, is you're going to take your preliminary impression. Usually we'll make a custom tray for your final impression, either closed or open tray. Then we'll pour a soft tissue model or a master cast. And before you do anything else, we're going to do a verification index to make sure that everything is verified, the impression is accurate. And once that impression, we have a verification and a base plate and bite rim is made, and then we do a setup and everything's verified, then we can make our bar, our hybrid type case. But it's really important to follow this protocol, from start to finish. And, at least the 5 parts here are the most important parts in the beginning of the case. So while we're on a subject of dentures here, what about full reline impressions on full overdenture cases? I get asked this a lot, so that's why I wanted to put this in the presentation here. So, when we're relining a locator denture or a denture that is an overdenture with different types of attachments, I recommend, first of all, there's a couple of ways to do this. So, some doctors send this to me with a wash impression without taking out the original housings. And many times what I'll see is impression material getting inside the attachment area or the locator attachment area, and it wasn't seated correctly. So if we do a reline in this, it's not going to snap back into place. So this is what I recommend. Grind out the denture housings or the denture caps from the denture, and you want to retrofit this denture, and you're going to take a new impression over new housings and new attachments. So this is what I'm going to do first. First, we're going to create space with a carbide burr, get those housings and attachments out of the denture. And there's special burrs that they sell. There's chairside recessed burrs and it's kits that they sell. Also, this is from Zest, and it gives you just the right amount of space for that locator or that housing. So once you create that space, you want to make sure, that, you place those new denture housings on the locator abutments, and you want a nice passive fit with the denture. So make sure once you place these on here and you want a nice passive fit, you're going to put the blackout spacer on here. These are the processing kits, the denture caps, and usually you're going to utilize a black cap or a low density male cap when you're taking the impression. But you can utilize anything. You can utilize some of the other more retentive elements in these caps also. So what I like to do is just make sure you have a nice passive fit, verify that passive fit. Sometimes we use a marking material that'll show you where it's hitting, and make sure there's no contact with those housings, those denture housings, or as they call it here, denture caps. Roughen up the borders, because if you look, you're doing an implant overdenture directly to the root attachments, directly to implant, we still need to rely on the borders, the tissue, and the attachments for retention. So what we're going to do is we're going to roughen up the borders, place adhesive on the borders, and do some border molding. And normally what we would do is add a heavy body or a monophase material around those borders, get the musculature, get a good impression of the musculature, take it out, and then you're going to also, now you're going to put your medium body to, I don't recommend a light body or medium body, at least when you're doing a reline material over the locator attachments. Before you do that, you want to put some adhesive in there. So put that adhesive in there, seat those attachments in the mouth, and then seat the denture and have the patient bite down into occlusion, into correct occlusion. And as you see the final impression here. And sometimes those denture housings will stay in the mouth, just pop them out and put them in the impression, or we'll put them back in the impression in the laboratory. So when this comes back to us at the laboratory, we use model analogs to pour the impression. We do a nice lab reline. There's your model analog here. And it pops right into the locator attachment. We'll pour a nice model and do a nice reline on it. And then everything's sent back to you. And you can either do these. You can cure the housings chair side, or we can do it for you in the laboratory. 90% of the time, we're doing it in the laboratory. So there's your locator reline for the lower denture. We'll process that in the laboratory, and it works. It's every time I utilize a reline like this with the locator attachments, we have a great success rate. So let's talk about best practices on full denture impressions now. So if you get a good preliminary impression, chances are we're going to get a good custom tray and a good final impression. So you can utilize a stock tray or take the impression with quality alginate material. Make sure you capture all those anatomical landmarks, even in that preliminary impression, because this is going to enable us at the laboratory to make a good custom tray for a final impression. And what we usually use is a light cured material for final impression trays. It's sturdy and strong, and it works well with final impressions. So when I'm making my custom tray, I go about 2 to 3 millimeters short of the border, and I'll block out any undercuts on the model. And why I'm doing this is going to enable you to the border mold this in the operatory. So we want to get the nice border molding of the impression on full cases. There's another tray here, 2 to 3 millimeters short of the border. And do we use tissue stops? Some doctors request tissue stops. I don't know. I say 80 to 90% of the time making custom trays, I don't utilize tissue stops, but it is a nice method, but you really have to make sure you're not putting too much compression. You see where this is a wax shim that's put on the model, and this is creating space for the impression material and also creating stops. So we cut out these 3 stops. Sometimes we put 4 stops on the lower, and that's going to enable you to stop the pressure on the tissue and enable that the space between the custom tray and the tissue for the impression material. But sometimes, most of the time, I see it's compressed too much, and we have to relieve the areas on the model and those spots there. And you want to make sure on an upper denture you're not going to be compressing the papilla. You see, this is just right to the incisive papilla here, and if you compress the papilla, it's not good for us too. We have to relieve that area, and we utilize the papilla many times to judge where we're setting our denture teeth. And on average, when we're setting our anterior denture teeth, we're coming 8 to 10 millimeters out from the papilla. So, so be careful where these tissue stops are put in the custom tray. So normally I'll go a little more to the right of the papilla here, and we'll have our tissue stops. But most of the time, I'm not utilizing tissue stops, and it works just fine. All these years making these custom trays and being successful with these types of cases, it worked well. And of course, we're blocking out the undercuts so that when you take the impression, you're not locking in these impressions. So it's plenty of room for impression material, so you can insert and remove it easily. And what about perforations? We get a lot of requests for perforations, but be careful, because especially with the PVS material, if it's a medium body to light body, many times the impression material just comes out of those perforations, and you're losing impression material. And the main thing, you're losing compression. So be careful of perforations. A lot of times we'll get asked perforations when an alginate impression is being taken, and that works out well. So the second visit is a custom tray impression. You know, first thing I'm going to do is you're going to place an adhesive on the borders and do a border molding like I showed earlier, and then we're going to have that's a heavy body material. Take that out of the mouth. Make sure you captured all those landmarks there, and paint the adhesive on, and put a medium to light body impression material. Most of the time when I'm recommending light body materials, if it's a full upper or full lower denture impression without any overdenture attachments, and it seems to work out well. But just make sure you capture all the borders and anatomical landmarks, including retromolar pads, hamular notches, and the frenum. Again, just a review from what you saw before with border mold. And some doctors still use compound, which is fine, as long as you get a good accurate impression of the borders. And we get the, you know, we need those good accurate border molding for a good fitting denture. As you see this particular photo here, you know, the actual, even the post-dam area was border molded here. So we have to be careful, because in the laboratory, when we're making these dentures, a lot of times we'll cut a 2 to 3 millimeter, we'll cut out of the model the post-dam, and we'll go into the model about 2 to 3 millimeters. And sometimes when there's too much material, like here, and we put 2 to 3 millimeters, it's actually going to push that denture out of the mouth. So we have to be careful, you know. So most of the times I don't recommend putting the material around the post-dam area, because we're going to do that anyway in the laboratory, unless it's a real problem patient that's had issues before with retention on full dentures. And what about a functional tray with a functional occlusal rim? This is probably one of the best methods I've seen, you know. And so you get a functional tray, which is pretty much a custom tray, 2 to 3 millimeters short of the periphery. And then we're putting an occlusal rim on top of that tray, and we're getting a good functional impression and occlusal records in one visit. So you're eliminating a visit, which is great. And there's the master models of the functional tray and functional impression. So then the bite registration using the functional impression with therapeutically designed bite rims is the most reliable way to transfer the oral situation to the articulator, especially when you have a semi-adjustable or fully adjustable articulator. And one step further, if you're using a Facebook transfer, that's a big plus also. So we got all the great information. It's almost like having the patient at the bench with us when we're working on these cases. So I love Facebook transfers on full mouth reconstruction cases, and that's a whole other seminar also. So we don't have time to get into that tonight. But that final impression, make sure you use a good accurate material. There's a lot of inferior materials out there. Just look at a good impression material that's accurate and consistent, and make sure that it's a high quality for better accuracy. This is a nice impression here. We captured all the anatomical landmarks, the periphery, the hamular notch areas, post-dam areas, retromolar pads, and it looks a nice impression. But what about this impression here? Well, you got pressure areas with probable overextension of the tray in those border areas. So what's going to happen with that? You know, that might be an issue later on, and actually pushes the denture out of the mouth, and it's going to go against the what we want as far as good retention. And we have loss of detail from excess saliva in this this impression here. So if I got this impression in the laboratory, I would probably make a new custom tray and maybe shorten the borders a little bit and ask the doctor to border mold it. But the main thing I see on this is it's usually utilizing a heavy body material with a full upper impression. And what happens sometimes, it compresses the tissue too much when you're taking an impression with this material. So, and this is just talking from as far as the experience over the years. You know, I think the last count I looked at, I made over 80,000 dentures over the years. So it's a lot of dentures and a lot of accurate impressions. So just make sure you use the right impression material. And how about this impression here? This is an actual case I got in the laboratory. I felt so bad for this patient. You know, look how far down the throat this impression material went. I mean, it's amazing. There's another shot of it. But if you look at this, you know, first of all that impression material probably had the patient sitting in a position where the patient was laying down. You wanted more of an upright position when you're taking an upper impression, a full upper impression. And if you look closely at this, the tray wasn't even border molded. So we get all that impression material going down the patient's throat. We don't have really a real accurate impression here. And on the anterior portion, it's, you know, really, it's not such an accurate impression. So I would recommend retaking this impression here. This is a nice impression, captured all the anatomical landmarks. I'd love to get something like this every time in a laboratory and removables. And this is that functional impression I talked about before. And the doctor really used a heavy body material to bore the mold. This doctor liked to use get full borders on the denture that impressions that he took. So this is a nice impression. We got a bite registration at the same time. And what happens when we get this back in the laboratory? You know, we put it on before the model, we put it on the articulator. We actually have to make new base plates. So we want to preserve the information that was given to us from the dentist. So what I do is, after I articulate this, I make a putty index, so I know exactly where the incisal edges are. We're going to end when we're setting our denture teeth. We have the midline, the cuspid line, the high lip line, everything we need, and then I make a new base plate, and I start setting my denture teeth according to the information the doctor gave me. So, and that's included in another one of my seminars also, as far as setting denture teeth and occlusion. So you can, we'll talk about that later at the end of the seminar, at the end of the webinar. And this is just setting the anterior teeth to follow the guidelines of the bite rim. And then what about pouring impressions? You know, and not only for denture impressions, but crown and bridge impressions, you want to make sure you're utilizing the right stone. And I know many times these models are poured in a dental office, but we want to make sure we utilize the correct stone with the correct mixing ratios. This can have an effect on the final fit of the restoration. So when I'm pouring a model for a full denture case, I use a type 3 stone or a yellow lab stone, and seems to work well. And the reason why I do this is because when we're deflasking our cases, when the case is processed, you know, we want that model to break first before the denture does. So we use a type 3 stone with less compressive strain, but it's still an accurate material. If it's a crown and bridge model or a partial denture model, we use the type 4 stone, which has more compressive strength. And use a vacuum mixer to get a nice accurate impression. But the important thing is to follow the manufacturer's guidelines on mixing this stone. You know, I've seen dental offices and dental laboratories mix stone where they just pour water in the bowl, keep on adding, gypsum to it. We want to make sure it's mixed accurately. You know, and at DSG and National Dentex, we have special mixing tools to mix these with machines and mixers with good accurate levels of accuracy when mixing our dental stones. So type 4 stone has a higher compressive strength, a very low expansion rate, and that's why we utilize it for crown and bridge materials, with crown and bridge cases also. So what about pickup impressions? When we're utilizing a pickup impression either for a denture repair, addition of a tooth, or even something like putting a crown under a partial. You know, an alternate impression is sufficient enough for this type of case, like here for this denture case. But what do we get? Sometimes we get a thick, heavy body material that's picked up this denture, and we've got to take this out of the impression. We usually break the denture again, so we have to be careful. And we have something like this, when we're doing a crown under a partial, be careful of a real heavy body material that's going to lock this partial in place, because many times it's hard to get that partial out of the impression material, and then we wind up warping and bending the partial. So just be careful. I wanted to touch on these pickup impressions today a little bit. So, all right. So let's touch on digital technology a little bit, and I'm going to take some questions. I'm just going to touch on some of the basics here. We don't have time to get into it today, but let's talk about intraoral scans with digital technology here. So what is digital technology? Digital dentistry is a method of gathering data, planning, designing, and manufacturing dental devices, and it aids the dentist in the diagnostic process. So it's great what we see on the screen now when we do IOS or intraoral scans. It's fantastic. So, but there's some criteria we want to follow. You know, the first thing is some of the basics is isolation and lip and cheek retraction. This is going to help you get a better digital impression. And there's a lot of tools out there that you utilize for that, and a lot of you know what these tools are. But these are some of the tools here: the Optigrate by Ivoclar, Vivadent, and Comfort View by Premier. Some of the tools you can utilize for retraction. And also, you want to, as far as saliva control, you want to make sure you have the isolation of saliva. And there's something called near-dry saliva absorbents by Microcopy. These are placed against the inside of the cheek and on the parotid gland to stop that saliva from flowing. That's really important when you're doing intraoral scanning. And also you want to make sure you have adequate preparation reduction and occlusal clearance prior to scanning. I can't tell you how many times we get scans or, even regular impressions in a laboratory and the bite is so close and we as a doctor can we reduce the opposing, but you don't have to worry about that if you're able to have some more clearance. So just make sure you have that clearance. There's something called prep check that you can utilize, and there's a lot of different choices where you can utilize different gauges for this. So that's really important to have that clearance. So, and there's always that opportunity for improvement. You can see it on the screen, like looking at inadequate tissue retraction or data capture. We see this on the screen right away, and you can capitalize on that inaccuracy and retake it. So, and we want to make sure we're utilizing the right retraction. So, a supragingival finish line is preferred. However, if subgingival achieving apical and lateral gingival tissue retraction is required in order for the optical device or scanning device to obtain data. And this can be accomplished with retraction cord, retraction paste, or both. We talked about it earlier, so I'm not going to get too much into the retraction part here, but you want to make sure, look at the top without the proper isolation or retraction, and look at the bottom picture with retraction paste, and what a difference in clarity here. Just make sure, some of the same rules apply in the analog that they go over to the digital side. So we want good gingival tissue retraction. And there's a lot of different materials out there with the retraction cores in combination with the, fluid material. So there's viscostat out there. There's a lot of choices to use out there as far as picking the right materials, retraction cords, and also retraction pastes. Okay, I'm not gonna, we talked about that earlier about retraction. So I want to just talk a little bit about the different types of scanners out there. Also, there's so many different types of scanners out there to choose from. It can get confusing. So do your research. If you need any help with this, we have an expert team here at DSG and National Dentex. We have field representatives that train and teach on this on a regular basis. So we're here for you if you have any questions. So this can be confusing. There's a lot of choices out there, like I just showed on the screen and what you see here. So, and a learning curve is, it's a little bit of a learning curve, even when designing what we do in the laboratory, designing, it's a learning curve, so there's a learning curve with scanning also, so as you can see here, as if you do 20 scans or more, it comes with practice, you can scan without even thinking, so you make sure you're utilizing the right scanning and utilizing the right protocol. And intraoral scans are great for fixed crown and bridges, onlays and veneers, implant abutments and crowns, and even partial dentures. We're starting to get a lot of scans on partial dentures also. And surgical guides, bite splints, orthodontics, and sleep appliances. So all those could be utilized for making an impression. And when we see a recurring problem like with impressions or intraoral impressions, we keep specific doctors' information. And when we see that high remake or high need on these impressions and they're not accurate, we'll evaluate it and then talk to you and maybe try to come up with a solution why this is happening on a regular basis. And our DSG digital implant workflow, we go all the way from the intraoral scanning, goes to the quality control to check that scan. And we're doing an implant case with the original manufacturer's implant parts. I want to make sure that we look at the quality control in these parts. And then we go to CAD/CAM production, again with quality control. We ship the restoration to you, and then you place the placement. So if you want to know more about this type of workflow and what's involved with protocol, just give us a call. We're here to help you. So, but what about intraoral scanning on full arch cases? Well, scanning is possible, but it's still not perfect. And additional steps must be taken, and case selection is critical. So you can use an indelible pencil to help with stitching issues when you're scanning a particular arch where there are very few landmarks or reference on this. So, but cases with tissue texture and landmarks will be easy to scan. But we want to make sure we capture all the anatomical landmarks, especially with making digital dentures now. Most of the scans we get are scans of the actual existing denture with a wash impression, and that works out really well. So there's been some studies done, and one of them was Professor Dr. LaRusso. He did a edentulous scan strategy, and it was designed. It's called Design for Optimal Scan Experience of Edentulous Patients. He utilized 3 shaped trios. And he did a directional scan, as you can see here on the left photo here. He started, on the crest of the ridge, going from one side to the other. Then he went into the palatal area, and then he went on around the periphery, and from one side that had Hammerlach to the other. And the same thing with the lower. He had a directional type of program that he used to get a good, accurate impression. He's been very successful with fully edentulous impressions. And then there was another study done by the Journal of Prosthodontic Research in February 2020. This was an in vivo feasibility study, and it was computerized optical impression taking of edentulous jaws for 29 patients. But they had a problem. Their conclusion said, within the limitations of the present study, the investigative scanners were not able to currently fully replace a conventional impression for the fabrication of a complete denture. So I had some problems, but look at their direction that they utilized. They went across, back and forth, back and forth, back and forth. So I think with Dr. LaRusso's presentation and his technique, you could probably get a better accurate impression, because it's been working well for him. So really important, before we end the presentation, take some questions. Just evaluate the accuracy of these cases before you send them out to the laboratory. Look at them under a microscope, make sure it's accurate. And because we hate hearing those 5 words in the laboratory, do the best you can. And so a lot of times we can't do the best we can on an inaccurate impression or an inferior impression, because it's going to wind up being a remake. So, but the ultimate goal is patient satisfaction. So we want to utilize the right techniques and protocol and the right materials. With that, I want to thank everybody for joining me today and joining us for this presentation. And we'll take some questions if we have time. Thank you.
Hi, Dennis. Thank you so much for the great presentation this evening.
Thank you.
Analog is so unique, and it's been around for so long. I love all the tips and tricks that you get into, the nitty gritty.
Yes,
so
thank
you. First question is, what causes pulls at the gingival margin, in parentheses, Invisalign impression, and how do I avoid it?
Okay, yeah. So a lot of those pulls is, just make sure, even with the as far as I mentioned before, just cleaning the whole area, even with the Invisalign impressions, clean those whole area and dry it completely. And I guess we're talking about PVS material, and that's just make sure it's dried and you're using the right viscosity. If you're finding out getting pulls, maybe with a light body or medium body, maybe utilize a heavier body material.
Great, thank you. And we have some hands raised. So first, I'm checking Dr. Chu.
Yeah.
Dr. So Young Chu. You'll have to unmute yourself to speak. We'll try the next, Dr. Gertzberg. Dr. Gertzberg, Yakov Gertzberg. And then I'll try Dr. Edward Pozonsny. I'm sorry if I'm pronouncing your name incorrectly. Dr. Edward Pozonsny. You'll have to unmute on your end. I've clicked ask to unmute for all 3 of you. Oh, there we go.
Okay.
Yep.
Oh, I didn't get that.
Nope, I didn't get any of that. So it'd be great if the 3 of you could type in the chat
type
box
in,
your
or
question.
else I'm going to show my, if you want to send me an email, and I can answer it at a later time if you can't, get that question across right now also.
We've got a couple more in the chat. Any suggestions for reline on full dentures?
Yeah, full denture relines, I still suggest, even if you could eliminate some of the undercuts in the denture, and still, if you find that the denture is really loose on a regular basis, just check out the borders also. I would just do maybe a little border molding on relines also, and use a light to medium body PVS material. and you want to utilize something that's going to flow correctly. And then, sometimes the doctors, a lot of doctors are using chairside reline materials too. And a lot of the chairside reline materials are PVS materials. And there's light and medium bodies also. But I think the best reline you're going to get, if you're going to do a chairside PVS, do a soft liner material and a laboratory process reline. But just make sure you capture all those anatomical landmarks and border molding, and either light to medium body material. I recommend, if there's not too much recession, and I would use a lighter body material. If there's more recession, use a medium body.
Thank you, Dennis. And what brand of polyether do you recommend? This person looked up Henry Schein and could not find any.
Okay, well, polyethers you can use. One of the is 3M Improgum. So it's one of the polyether impressions that's pretty much utilized. Just go if you go. There's so many brands out there. That's polyether is probably that's one of the more popular ones.
Thank you. And then Elagenate or PVS for immediate dentures?
Good question. Okay, so if you have, if you can get it, I've gotten some great alginate impressions for immediate dentures and captured all the anatomical landmarks. And if you capture everything and you have those all anatomical landmarks in the impression, then by all means we can go to a finish on an immediate denture. And then these dentures are going to be relined anyway. So if it's good impression, go with the alginate. If it's a PVS material, and if there's a lot of undercuts, sometimes it's difficult to get a good PVS impression with an immediate denture. But even with we're even getting some good digital scans on immediate dentures also, because we're capturing the natural dentition and trying to capture all those anatomical landmarks near the periphery. We seem to be getting more and more good successful impressions with these also, and we're able to design so efficiently an immediate denture using digital technology now. But yeah, if you go back, again, if you get a good alginate impression, we can utilize that. But if you can get a good PVS impression with something that's really not that undercut, I think you're in good shape here. Otherwise, you'll have to get some pulling and tearing in the impression material.
Thank you, Dennis. I'm going to jump to another question because it seems to correlate. Any preference between PVS or polyether?
I like the PVS material. So, and there's so many great PVS materials out there, so many viscosities to choose from. And I just like PVS material. Mainly because I've been successful with it. I'm not bashing, polyether materials either, because, we get a lot of polyether impressions, but I'm thinking back even when I had my laboratory, most of the time, we were using PVS materials. And then, at that point when I sold my laboratory at that period of time from I think it was 1994 to 2005, I was working for an impression material company, and we did mostly PVS impressions in a successful manner. So my personal preference is PVS.
Great, thank you. And do you use intraoral scanning for edentulous patients?
Yeah, so if you can capture, like I talked about before, it's getting better. I think I think it's such an evolving technology. I think in the next year or so, you're going to see some really accurate intraoral techniques with intraoral scanning. But right now, the most difficulty we have is when we have a ridge that's really undercut, and a lot of times just getting back to the retromolar pad areas, even towards the hammerlin notch areas for impressions. But if we have a ridge where we have tissue texture and it's not that undercut, we're getting successful impressions. But a lot of times what we recommend is if you think you can't capture all those anatomical landmarks, take a wash impression, with the medium body or light body impression material, and scan the impression and send it to us. And this actually eliminates a few visits. If you have an existing denture where you can take a wash impression inside the existing dentures, say if it's a full upper and full lower denture, wash impression, you can scan that impression and send us the STL file. And then you can also take a bite registration. So yeah, you just eliminated the final impression visit and the bite registration visit, and we can go right to a printed setup for you on that. So, but yeah, we're getting some good success with fully edentulous cases, and it's getting better and better as we go along. So, but the majority of cases that we're getting, as far as digital scans of fully edentulous cases, have been with scans on an impression or a wash impression.
Thank you, Dennis. And then somebody's asking to please review pitfalls in using the hemostatic agents like clear or yellow from Ultradent.
Okay, can you repeat that again?
Please review pitfalls in using the hemostatic agents like clear or yellow from Ultradent.
Right. Yeah, the hemostatic agents you want, they work well. And I like the working in conjunction with cords too. But some of the pitfalls I see is just when you're taking impressions, not cleaning that area enough. After your retraction. So just make sure those areas are really clean, and then before the impression is taken or the scan is taken. Those are pretty much the pitfalls I see. But I've seen such great success with these types of materials. Ultradent, I personally I haven't utilized Ultradent. So I'm not, but I'm sure it's the same type of aluminum type material that like the other materials on the market.
Thank you, Dennis. This question I can answer. We've been asked where they can access the recording for this webinar. All of our education content is recorded and posted on our YouTube channel of DSG Education. You may access the link at www.dentalservices.net/edu. It's right at the top of the page. Also, at the close of every webinar, we do send the recording link in a follow-up email, which typically follows 3 to 5 days post-session. So thank you for learning with DSG. And with that, I will turn it over to you, Dennis, to close us out.
All right. Thank you, Jessica. And thank you, everybody, for joining us tonight. I really appreciate it. And this is what I love to do. And to have an audience like you, it really means a lot. So we hope you all had a positive learning experience today. And may you apply your knowledge and expertise in a positive way, in a way that will enhance your careers and your self-worth. Have a great day, everybody. And thank you for joining us. Bye-bye now.